Hi everyone, it's Paige, and this is my narrated journal review for differential diagnosis and physical therapy. The patient in this case was a 67-year-old Caucasian male and was referred to PT for musculoskeletal back pain and paraspinal spasm. During the initial observation, the PT noted that the patient was in obvious pain, and during the interview process, the patient noted that the pain began 2 weeks earlier and was so severe that he had to go to the emergency department, at which they did a CT scan, which was negative for aneurysms as well as bony pathology. The patient's pain was so severe in the emergency department that he couldn't complete the evaluation until they gave him morphine. And then they discharged him with some opioid analgesics and said to go back to his primary care physician if the pain persisted. So after 10 days, he went back to his primary care physician. The patient also denied any pre-existing medical conditions. The patient described the pain as being diffuse in his low back. He also denied any pain in the chest, abdomen, or lower extremities, as well as denying recent fever, illness, or weight loss. Pain was relieved with medication or lying in the right sideline position and exacerbated by prolonged sitting and changing positions. At worst, it was a 10 out of 10. At best, it was a 2 out of 10. And sleep was significantly disrupted by the pain. The patient was unable to do any activities of daily living without assistance from his wife or additional time, and he was unable to return to work. As far as goals, he wanted a complete resolution of his back pain, and he wanted to be physically capable to go on vacation 3 weeks from the PT eval. This is a summary of the evidence, both supporting and rejecting a musculoskeletal cause for the pain. Further PT examination was limited due to the pain, but she did note that the posture was antalgic and he had a left lateral shift of the trunk. He was unable to perform a sit-to-stand or walk without assistance from his wife, and his range of motion in his trunk was significantly limited in all directions. Neurological examinations were normal, and palpation revealed trigger points and spasms along the paraspinal musculature. The therapist started the patient with some ultrasound and manual therapy techniques, which helped to relieve some of the pain and allowed him to lie in supine. Once in supine, the therapist started some single-kneaded chest stretches, during which, when she lowered his leg back down to the table, he had complaints of pain wrapping around the upper abdominal region. This pain provocation led the therapist to complete more screenings in regards to abdominal pathology, and the patient revealed that he had not had a bowel movement in the past 3 days and had complaints of abdominal distension. Palpation of the 4 abdominal quadrants provoked a diffuse pain throughout the right and left upper quadrants with apprehensive muscle guarding. The PT immediately referred the patient back to the physician, where he got abdominal radiographs, which revealed significant retention of stool in the right colon, or the ascending colon, and a lack of stool in the descending colon. When they looked back at the CT scan from the original emergency department visit, they were able to see this mild bowel dilation, but they were more focused at the time on ruling out aneurysm and bone pathology, so they missed this, unfortunately. And the final medical assessment was that the patient's abdominal pain and distension was due to severe intestinal constipation as a result of decreased colonic motility secondary to opioid analgesic medications, and their treatment for this was enemas. Although the patient had a complete resolution of his abdominal symptoms, he still had back pain, so he went back to PT and he progressed wonderfully. Within 3 weeks, he was able to achieve all of his goals. This case highlights why it's so important to get a thorough interview of your patient and to also complete continuous medical screening even into the treatment sessions after the initial evaluation. It's also important to assess your patient's medications, whether they're on them currently or whether they were recently on them, and to assess their side effects to see if it's maybe having a relation to your patient's pain. And also, constipation's no joke. It can lead to severe medical issues if not treated. So, thanks for listening.